Hello, my name is Dr. April Ruffin. I'm an OBGYN in the Atlanta area, and I also work for Anthem as a medical director. And so I'm very excited to be here today to talk to you all about maternal child health. And specifically for my presentation, I wanted to talk about the importance of preparing for a healthy pregnancy. I know that in the media, we hear a lot of bad numbers. We hear a lot about maternal mortality. And so when we hear those numbers, a lot of times we think, what can we do to impact, what's happening at that very moment? But I think it's very important that we look at the whole picture and look at what happens in the very beginning. And even before a person becomes pregnant, what can we do to prevent those? That it's so important to plan a pregnancy if we can. So let's see. Okay, so just quick disclaimer, this presentation is for educational purposes only, and I have no paid endorsements to disclose. So today, the things I want us to cover, we're first going to just kind of talk about the state of maternal child health in Georgia. Then we're going to talk about the importance of a planned pregnancy. And then I want to touch on a couple of little innovative ways to do prenatal care that we've started doing within the last kind of 10 years or so. And then I want to talk about the importance of the fourth trimester and postpartum care and how that's so important in planning for the next pregnancy. So as far as the state of maternal child health in Georgia, the March of Dimes every year puts out a report card, and nationally, we have the USA, we have a grade of C-. And so certainly that is not good. Our national preterm birth rate is 10.1%. Here in Georgia, unfortunately, we fall even lower. Our preterm birth rate is 11.4%, and that gives us a grade of D-, and we are 45th nationwide. And this is just a map that the March of Dimes puts out every year, and as you can see, Georgia, we have a C-. I'm sorry, nationally, we're C-, Georgia, we have a D. And if you look in the Southeast, there is a lot of work to be done. We all in the Southeast, all the states either have an F or a D. And Georgia actually just went up from an F this past year to a D. So, certainly there's a lot of work that needs to be done in this area. As far as the maternal death rate nationally, we have a rate of 17.3 out of 100,000 live births. 13.4 for white women and 41.7 out of 100,000 live births for Black women. That's nationally. And for Georgia, it's even worse. Our maternal mortality rate, we actually have the worst of all states. It's 25.1 out of 100,000 live births, 14.3 for white women, and 47 out of 100,000 live births for Black women. So Black women in Georgia are 3.3 times more likely to die in pregnancy. And this is across all educational levels, all income levels. Doesn't matter if you are Black, you are a Black woman, you are at increased risk of dying in the state of Georgia above everyone else. And health experts believe that more than half of these deaths can be prevented. We know that the leading cause of pregnancy-related death are cardiovascular conditions, and those are 15.5%. Some other numbers, in Georgia, the C-section rate is 33.9%. In the US, the C-section rate is 31.8%. So Georgia, again, we have a worse C-section rate than nationally. Georgia ranks 43rd in the country for infant mortality and 45th in the country for low birth weight babies. And Black babies are twice as likely to die as white babies. What's interesting is that 23% of Black women and 49% of Hispanic women do not have a personal doctor or a healthcare provider. And when we talk about the importance of planning a pregnancy, this is key. If you don't have a doctor that you're seeing outside of pregnancy, then there's no one to make sure that you are medically idealized before becoming pregnant. Half of all counties in Georgia have no OB physician. 46 of Georgia's 159 counties have a labor and delivery unit. And Georgia has not expanded Medicaid under the Affordable Health Care Act, and 17% of women ages 19 to 64 are uninsured. So ladies who are of reproductive age are uninsured because we have not expanded Medicaid under the Affordable Health Care Act. So this is a map of Georgia that the Georgia Department of Public Health puts out. And this is just very telling. If you, look at this map, if you look up here in the area kind of mid-east, you'll see a lot of pink where there are no OB providers. You see a lot of red X's where labor and deliveries have closed. My mom is the oldest of 12. She actually was born at home, but many of her younger siblings were born at this labor and delivery in Elberton. And, see, if you can see there's a big X there now, there's no labor and delivery in that area. And all those patients now have to go to Oconee or to Athens. They are driving very far to even get to a labor and delivery. So that's a problem. That's where disparities happen. And we're just talking about an OB, but for patients who are high risk and need to get to a perinatologist or MFM, they're driving even further. And so that is where you start to see complications. So this is a very real issue that we need to address here in Georgia. So why is planning a pregnancy so important? We know that 45% of all pregnancies in the US are unintended, and certainly unintended pregnancies are there are increased risk. There's an increased risk of pregnancy complications. Also, we surveyed women, and a third of women who gave birth in Georgia reported that their pregnancies were mistimed or unwanted. So even those ladies who went on to continue their pregnancies, a third of those said that their pregnancy was mistimed or unwanted. And again, we know that unintended pregnancies, there are increased risk of complications. So the goal of planning a pregnancy is to reduce the risk of adverse health effects for the woman, the fetus, and the neonate. And the goal is to optimize health, to address modifiable risk factors, and to educate about healthy pregnancy. So there was a clinical work group of the National Preconception Health and Healthcare Initiative, which proposed 9 core targets when talking about preconception wellness. And I also wanted to throw in a few of my own targets that I think are key. So the first one is the absence of tobacco and substance use. And this just seems like a no-brainer. Like I still can't believe, that people smoke. We know how bad smoking is, but it's just crazy, mind-blowing to me that 10.5% of women can continue to smoke during pregnancy. And we know that there's an increased risk of birth defects, low birth weight, preterm birth, IUFD. So it's so important with these patients to screen early before becoming pregnant, intervene, talk about different interventions so that they can quit, and refer for treatment, because we know that it improves maternal and infant outcomes. Also, it's important to address partners. We know that when patients' partners continue to smoke or use substances, then those patients, it's harder for them to quit. So certainly we want to, emphasize it with the patient, but also with the partners as well. And we also know that secondhand smoke increases the risk of SIDS. So that's another reason for partners to quit smoking as well. Okay, the next area is addressing uncontrolled depression. Antenatal uncontrolled depression is associated with increased risk of multiple adverse obstetrical and neonatal outcomes, including pregnancy loss, operative delivery, and preterm birth. We also know that it's associated with abnormal infant-child development, as well as cognitive problems and psychopathological issues in the offspring. So uncontrolled depression has to be addressed prenatally, ideally. And ideally, first line treatment would be psychotherapy, including yoga, exercise, meditation. But if depression cannot be controlled with those and we need to go to medication, then we have to. We know that the benefits outweigh the risk. So this is an area where certainly, it's a collaborative interaction with the OB, the psychiatrist, to determine what is the safest medicine to use in pregnancy if needed. Okay, so next one would be absence of sexually transmitted infections. And this is just an easy thing that can be taken care of, prenatally by screening before the patient is ever pregnant. You want to check for any STIs, because we know patients who are pregnant and have STIs are at increased risk of preterm labor, birth, premature rupture of membranes, PID, low birth weight, birth defects, eye infections, sepsis, death. These are all complications that could be easily preventable just by treatment before getting pregnant. Also, we definitely want to test patients for HIV and go ahead and get them started on antivirals if they are HIV positive, so that the CD4 counts can be at a level, or undetectable, so that the patient has a decreased risk of transmission to the baby, and then also so that they could have a vaginal delivery. So teratogen avoidance, again, this is something that can be addressed in the pre-pregnancy planning stage. We know that 4 to 5% of birth defects are caused by exposure to teratogens, and the most common are going to be your prescription medications, like your seizure medications, antibiotics, hypertension medications, alcohol, tobacco, radiation, infections. So certainly in that stage before becoming pregnant, meet with the doctor, go over those safe during pregnancy. And again, we go back to some of those numbers that I talked about in the beginning, where you have 50%, almost 50% of Hispanic women who don't have a primary doctor. So if you don't have a doctor reviewing these medications and you show up at the OB when you're already into the second trimester, then you are at high risk of having, a teratogen complication. And teratogen exposures are associated with increased risk of miscarriage, birth defects, preterm labor, low birth rate, and stillborns. The other thing to know is that the impact of teratogens also depends on the timing and length of exposure, the stage in the pregnancy, and also your own genetic susceptibility and the type of agent. So, so that's something, that you also, we will also look at if there's a potential exposure. So the next area that's so important in pregnancy planning is to make sure that you are at a healthy weight, or that the patient is at a healthy weight. Unfortunately, 64.8% of adult Georgians are overweight. I mean, that number just blows my mind, 64.8%. And not only that, 30.5% are considered obese. And these numbers are from 2014. So this is pre-pandemic, so I'm sure those numbers are bigger now. Everybody put on a little bit during the pandemic, but this is so important. It is, I cannot emphasize how important it is to try to get down to a healthy weight before becoming pregnant. We know that obesity increases the risk of hypertension, preeclampsia, preterm birth and labor, gestational diabetes, macrosomia, birth injury, C-section, birth defects. All of these things could be prevented, or the risk can be reduced just by starting the pregnancy at a healthy weight. And it's not just being overweight. Patients who are underweight also have increased risk, including risk of preterm delivery, fetal growth abnormalities, and miscarriage. Okay, another target is folic acid supplementation. And this is so important. Again, this is a birth defect, or these birth defects can be prevented simply by folic acid supplementation. And I always tell my patients to make sure you're on a folic acid supplement at least 3 months prior to conception. And actually, all of my patients who are of reproductive age, I recommend that they go ahead and start on a prenatal vitamin. Okay, because remember what we mentioned early on, 50% of all pregnancies are unintended or accidental. So most patients are not even trying when they become pregnant, which is why it's so important to go ahead and be taking a prenatal vitamin, all women of reproductive age. We know that folic acid deficiency is associated with neural tube defects. There's also association with cleft lip palate, congenital heart defects, limb reduction defects, urinary tract defects, congenital hydrocephalus. All of these are folic sensitive congenital malformations. FACOG recommends at least 0.4 milligrams of folate for low risk women, and 1 milligram is recommended for high risk women. And those would be women who have had a baby previously affected. Also, something to remember is that there are certain medications and surgeries that are associated with malabsorption. We also want to remember our patients who are on special diets, those ladies who are on low carb. They may be at higher risk of folate deficiency because breads and pastas are fortified with folic acid. And if they are not eating those because they're on low carb, then they may not be getting that, extra benefit. Also, people who are on organic diets, organic foods are exempt from folic acid fortification regulations. So those patients we need to address to make sure that they're getting adequate supplementation. Okay, another key target is going to be glycemic control. These are our patients who are diabetic, who are pre-diabetic, or who had gestational diabetes in a previous pregnancy. These patients need to make sure that their blood sugars are adequately controlled prior to even becoming pregnant. Ideally, you want that preconception A1C to be at least less than 6.5%. We know that perinatal death increases as that A1C increases. Adverse pregnancy outcomes from suboptimal glycemic control include miscarriages, congenital anomalies, macrosomia, preeclampsia, preterm birth, C-section birth, and perinatal mortality. The mom can also have issues. She can have progression of retinopathy, nephropathy, diabetic ketoacidosis, gastroparesis. And then there's also neonatal morbidity, including hypoglycemia, hyperbilirubinemia, respiratory distress, cardiomyopathy. So certainly we need to make sure that our patients, that their blood sugars are very well controlled, even becoming pregnant, certainly at the very beginning of the pregnancy, because that in that first trimester, that is when organogenesis is happening, and that puts that lady, the baby, at very high risk of having congenital anomalies if the blood sugar is not controlled. Also, there are long-term adverse outcomes for those offspring. It increases the risk for those babies of diabetes, obesity, as well as cardiometabolic outcomes. Okay, another target is going to be access to care and that first trimester prenatal visit. When you're planning for a pregnancy and you're talking to your patients in that pre-pregnancy visit, you want to make sure that they know it is so important that you get in to see your OB as soon as possible. 16% of women will not start prenatal care until the second trimester. And 6.4% will receive no care or late prenatal care. So that puts women at significant risk of having outcomes. So it's so important that patients know they need to get in and have that first prenatal visit as soon as possible. And this goes back to the access to care piece. When we look at that map of Georgia, and we have all these OB deserts where patients don't have an OB and, unfortunately can't get in to see an OB until later on. It is so important screening, nuchal translucency, and again, to make sure that all those chronic medical conditions are under good control. Another thing to talk about is birth spacing with planning pregnancy. You want to avoid pregnancy intervals that are shorter than 6 months. We know that that increases the risk to the mom. And if the birth spacing is shorter than 18 months, there's an associated elevated risk there's an associated perinatal risk. You also don't want to go too long in between your pregnancies. It's always interesting to me, the patients who have a 1-year-old and a 10-year-old, like, oh my gosh, I can't even imagine that. But there is actually an increased risk for dystocia and preeclampsia if there's a huge window, or at least more than 60 to 75 months interval between pregnancies. And this is just a chart, just again, showing if there's a shorter interval, the increased risk, and then if there's a longer interval, the increased risk. And like we talked about with shorter interval, increased risk of low birth rate, small for gestational age, preterm birth, increased risk of uterine rupture, miscarriage, stillbirth, severe maternal morbidity with transfusion and without transfusion, and also with the long-term, the preeclampsia, you see that. Okay, so the next target is just planning a pregnancy, things that you want to do in that period when you're planning a pregnancy. Very important to look at the family history and to recommend genetic testing if necessary. If based on the history, it sounds like partner, then certainly you want to send them for a genetic counseling to see if there is, possibly an inheritable disease. And in doing that, patients can also make decisions for how they want to grow their family. Do they want to do IVF with PGD? Do they want to use a surrogate? Do they want to, adopt? Those are things to talk about when looking at the family history and, especially if there's a concern for a genetic disorder. Also make sure that the mom is immunized, all of her immunizations are up to date. And then something that I think we struggle in as providers is, looking at the total patient and talking about the social determinants of health, any disparities, ask about housing, access to food, safe drinking water, are they safe at work? Do they live in a safe home and community? Definitely you want to ask about partner domestic violence. Those are things that would certainly impact a pregnancy. So we want to, before that even happens, make sure that conditions are ideal. And then, of course, we want to optimize all chronic medical conditions, high blood pressure, diabetes, thyroid disease, asthma, heart disease, epilepsy, HIV, autoimmune, mental health, all those things. We want to make sure that the patients are on pregnancy-safe medications and that they are optimized. Chronic medical issues can be associated with infertility, preterm birth, birth defects, pregnancy loss. So certainly we want to make sure that those are controlled. And when we're talking about chronic medical conditions, there are some patients who would be, very, very high risk. And so it's important, again, to talk with patients about how they want to grow their families. Do you want to use a surrogate? Do you want to foster? Do you want to adopt? Maybe someone is not the best candidate to be pregnant. And so certainly it's better to talk to that patient about that when they're not pregnant than when they already are. Okay. And of course, when you're talking about planning a pregnancy, it's important to talk about contraception and birth spacing. And this is a good little guide. This is mainly for postpartum contraception, but you can use it for patients who haven't become pregnant yet. Just when are you planning to have a baby? Do you want something long acting like a LARC? Do you want to just use like OCPs? Can you remember to take a pill every day? Is this patient postpartum? Are they breastfeeding? Do you need something that is compatible with breastfeeding? Also, you want to talk about side effects and, safety as far as if they have any chronic medical issues. So all things to consider when talking about contraception. Certainly postpartum, when you're trying to, make sure that the births are spaced appropriately. And then also for anyone who maybe wanting to get their chronic medical conditions under control, then, you want to talk about contraception. Okay, so I wanted to touch on just very quickly some innovative ways to do prenatal care. And one of the newer ways is with group prenatal care. Some people have heard about it, some people haven't, probably the majority of you have. And it's basically designed to improve patient education and opportunities for social support while still maintaining the screening and the physical assessment of the individual patient. So the patients will still have their one-on-one visit with their doctor, with their midwife, and then they come together as a group, like everybody who's 12 weeks or 20 weeks or 36 weeks. And at that point, the doctor can, or midwife can answer whatever questions the group has. And what we have found is that, a patient may not even realize that they have that same question. And so patients are just very well educated and they have that support. And what the studies have demonstrated is that with group prenatal care, there's a reduction in preterm birth, NICU admissions, decreased ER visits, there's improved knowledge of childbirth and family planning, and also increased rates of breastfeeding. Also, something that we're seeing used more and more are doulas and doula care. Doulas provide physical and emotional support during pregnancy, childbirth, and the postpartum period. What's interesting is only 13 states reimburse for doula care. We know that expectant mothers with doulas have better birth outcomes and that they're 4 times less likely to have low birth rates, and they're more likely to initiate breastfeeding. There was a meta-analysis done of randomized trials comparing continuous one-on-one labor support with the usual care. And they found that there were improved pregnancy outcomes with no harm. And this was not specific to doulas. This was just patients who had some type of one-on-one labor support, which certainly could, translate to doula care. But, it showed that there were certainly improved pregnancy outcomes, increased spontaneous vaginal births, decreased C-section, reduction in medication use for pain, reduction in low 5-minute APGARs, reduction in negative childbirth experiences. So this is something, that I think we need to use more and more. And hopefully now that, pandemic restrictions are starting to lift a little bit, we can get some more doulas into the labor and delivery room. The last thing I wanted to touch on is just optimizing postpartum care and that 4th trimester. 52% of maternal deaths occur after delivery, and 19% of those occur in the first days, and 21 occur between the 1st and 6th week. 40% of women do not attend a postpartum visit, and that's just crazy to me. But moms, are so busy with taking care of themselves, taking care of their babies. Some ladies getting back to work so quickly after having a baby that, unfortunately, we are at a point where 40% of women do not go to their postpartum visit. And when we talk about planning for that next pregnancy, this is a key time. The weeks following birth are critical for the woman and the child. And we know that postpartum care should be ongoing. It should not just be a single encounter. And this is something that FACOG has recognized and other organizations, and we're looking to improve that. Ideally, that initial contact should occur within the first 3 weeks and then should tailor from there, including even possible postpartum home visits, or certainly, now we could even do virtual. This is just, something to look at as far as maternal and pregnancy related deaths. 31% happening during pregnancy, 17 on the day of delivery, and then again, showing here the 52% occurring postpartum. So, just a very key time that we need to connect with patients. And we know now that, we shouldn't just be sending patients out saying, we'll see you back in 6 weeks. And not even 40% don't even come back at that 6-week mark. So that postpartum period is so important for addressing reproductive life plans, timing of future pregnancies. We also want to talk to our ladies to let them know if they have pregnancy. And also patients who have gestational diabetes, hypertension, they have a higher lifetime risk of cardiometabolic disease. And this is just a table just showing some of the key areas that you want to touch on during that postpartum care. Certainly mental health, talk about the baby, is the baby feeding well, especially now with everything going on with formula shortages. Make sure that, the baby is being fed. And, again, addressing those chronic medical conditions that may have presented during pregnancy. And that's it. Thank you so much.